Okay, well, let's go ahead and get to the next presentation. Ninh, I don't know how you're going to do this. It's going to be hard to beat. So one of the biggest honors and privileges to be an immediate president of the ASMBS is that we get actually to introduce the president of the ASMBS during their presidential address. So before I start my introduction, I wanted to tell you a couple of things. So Ninh asked me to be brief, and I'm going to try to do that. But he also asked me to be very serious on this presentation, that this is a formal presentation. And Ninh, I am going to try to do that, but I have to be a little bit funny to entertain the audience. Don't worry, it's not going to be too bad, but I have to do it. So I have the honor to introduce to you Dr. Ninh Nguyen. Ninh was born in 1965 in Saigon, South Vietnam. Now, after the war, Saigon has changed the name to Ho Chi Minh City. Ninh, as you can see here, has 2 sisters and 1 brother. According to his mom, which I have to recognize that Ninh's mom is here with us, Miss Anna Nguyen, and his mom tells me that when he was taking pictures, he always hated that. He was annoyed by taking pictures. The only fun thing for Ninh about taking pictures with the family was that when he got to bother his little sister during the pictures. So this is Ninh, very focused, very serious, always very determined. He has an older brother and a younger sister that are dentists, and an older sister that teaches piano. They all live in Southern California. Ninh, this is them again. And this is Ninh with his mom. And this is still when they were in Vietnam and with his dad and his family. Ninh has 7 nieces and nephews. Ninh was always interested in developing skills with his hands. You know, as you can see here, he liked to play piano, and those skills became handy later on. He also played violin when he was a teenager and became handy when he became a laparoscopic surgeon. But he also wanted to be a cool kid when he was little, wearing his nice glasses, posing for the picture, and he was always looking for those beautiful roses for somebody in front of him. Now, this is Ninh, a little bit older, just before they left Vietnam with his brother. And Ninh lived, and this is his house in Vietnam. And Ninh tells me that recently his mom went back to Vietnam, and he found out that on the house that they were living at that time, now there's several families living there. So government changed and politics changed, but this is where he grew up. Now, Bruce Wolf tells me a story, which it's very interesting. So Ninh's family fled from South Vietnam in 1975. And at those closing days after the Vietnam War, they led to the establishment of 3 evacuation camps for these urgent immigrants. And those camps were, one of those camps were Camp Pendleton Marine Corps Base in Southern California. And Bruce Wolf actually was one of the staff surgeons at that time. And it was mandated that all the refugees at that time were interviewed and examined by one of the Marine Corps physicians before they were cleared to leave the camp at Pendleton. Now, we don't know, and we have no idea if Bruce Wolf actually met Ninh there or later on at UC Davis, but potentially his career in bariatric surgery started sooner or earlier than what we thought. Now, Ninh, as a teenager, this is the rest of his family now in California, I was told that he was always an A student. He's very dedicated to school. He wanted to be a doctor since he was very little. And actually, it's an interesting story. When he was 16 years of age, he was given a B on a test. He always got an A. And so he got upset. So he went and talked to the teacher and said, well, I want to see the test. I want to see the test. Why did I got a B? Well, the results are done and the tests are destroyed, so you got a B, and that's it. So he got upset, and he quit high school because he was not happy with a B, and moved on to start college early. So actually, he finished college at 20 years of age. So this is Ninh. Ninh always was an A student, always first of his class, always dedicated to school. Finished medical school in UT San Antonio with a Dean's Scholarship Award, Intern of the Year. Developing all the type of things that you will do to build an academic career, best resident papers, fellowship awards. He won every single thing that you need to do to become the top of his class and become what I call an academic surgeon. He finished a fellowship of minimally invasive surgery and surgical oncology in the University of Pittsburgh from 95 to 98. And today he is a professor of surgery at UCI. He's the vice chair of the Department of Surgery at UCI, and he's the chief of gastrointestinal division at UCI. So as you can see, he has built an academic surgery career. But with his early experience in the fellowship in minimally invasive, he also was tried to adopt and utilize that laparoscopic approach in bariatric surgery, and at times in which many surgeons were not using it, and many surgeons were still questioning the validity of that approach in complex cases in bariatric surgery. So Ninh, I consider that he's part of this initial documentation of how laparoscopic approach can be used in bariatric surgery. In that documentation, early findings, he found that 75 Roux-en-Y cases were needed to overcome the learning curve. He did one of the first randomized clinical trials compare an open approach to laparoscopic approach for Roux-en-Y. He found what we know: less pain, less complications, quick recovery. He also initiated randomized clinical trials on times in which we were questioning the ability to do those studies because it was thought it was impossible to do them. He published innovative first case reports. He has reviewed all the bariatric databases and has published a significant number of publications in bariatric findings. All these early findings in his academic career were recognized by his peers. As you can see here, this is the editorial board of obesity surgery on the early years. And you can see young Ninh there with all the most senior members of our bariatric surgery community. So Ninh has been recognized as an academic surgeon very early. Now, in regards to the ASMBS, Ninh is always has been very dedicated. Many of the staff members of the ASMBS can tell you that. There's Christy, and she can witness how Ninh is always dedicated and always has some work to do for them. Always very responsive. You can ask him a question and he'll answer you quickly. He's efficient. He listens. But he also likes to have fun. When he was little, he liked to be in the pool, in the water. You can see in that picture that actually he's smiling, so he likes to be in the pool. And that hasn't changed as an adult. Likes to be in the pool. Now, whoever hangs out with Ninh, he can tell you that he loves to eat salads. He will get the biggest salad in the world, and that will be his meal. He enjoys salads. He also enjoys, for dessert, berries. And that is, everybody that knows Ninh, and we had that last night, and every time that he has an opportunity to coordinate and regulate the menu, we will have berries for dessert. But he knows how to eat protein. I can tell you that I've seen him, and we all see him occasionally eating some protein. Even though he struggles at times to eat a piece of shrimp, he can do it. And as many probably question, he can also eat carbs. So this is Ninh's eating habits. Now, as a leader, Ninh always has been very attentive, as I said, listening to all the details, all the differences in between academic and private practice, and trying to understand, like a good researcher, what is the problem and how we can find solutions. He's very calm. He doesn't want to get into conflicts, but when it's the time to fight an issue, I can tell you that he can be a Hulk. So he's a fighter, and he has fought for our society hard. His fellows, he has trained a lot of fellows that are members of our society that have been in the leadership. This is Brian Smith. Have tell me that as a mentor, he's one of the best teachers that they have had. They actually have supplied to me his exciting methods of training that he has at home. So he likes to hold hands of the fellows to teach them how to do laparoscopic surgery. And another thing that his fellows tells me that he probably has a double personality that we're not quite sure what it is. Maybe he's a 007 agent, but this is Nin's license plate. So he is a cool guy, huh? So Nin, to me, he had a devotion to make an impact on the ASMBS, and you're going to see that on his presidential address. So it is an honor for me to introduce a true academic leader in bariatric surgery, a surgeon that to me is part of laparoscopic bariatric surgery history. It is a colleague, it is an advisor to me, and it is a very good friend to me. So I have here with you the 28th president of the ASMBS, Dr. Ninh Nguyen.
Thank you, Jaime. Appreciate all of your kind comments. Member and guests, we have a treatment, and that treatment is ingrained within our organizational name. That is metabolic and bariatric surgery. This treatment has been shown to be safe, actually very safe. We as a society took action and continued the success. When laparoscopic was initiated, the ASMBS responded with education for laparoscopy, and as you can see here, with significant reduction in the mortality over time. In 2004, we initiated the Bariatric Center of Excellence accreditation, and we further improved the care of our patient. Now bariatric surgery is even safer than that of gallbladder surgery. It is safe as common general surgical procedures such as anti-reflux operation. It is effective. Randomized control trial has shown weight loss significantly better after bariatric surgery compared to a control cohort at 3 years. It caused remission of obesity-related comorbidities, particularly for type 2 diabetes. There are no other operation out there that can result in such a profound effect on so many bodily organs. Bariatric surgery has been shown to result in improvement of the cardiovascular system, the pulmonary system, urinary system, endocrine system, and musculoskeletal system. It improves quality of life. We all know that quality of life for obese individual is depressed compared to the US norms. And it dramatically improved within a relatively short period of time after bariatric surgery. Within 1 year after bariatric surgery, the quality of life of patients who underwent bariatric surgery increased substantially to be similar to that of the US norms. This treatment also improves survival. Studies have shown a 40% reduction in all-cause of death in patients who underwent bariatric surgery compared to a control cohort. So if you look at this graph, the laparoscopic revolution, as I call it, has really resulted in exponential growth in the number of bariatric procedures in the US. Certainly, with reduction in the invasiveness of this operation, more patients were willing to accept bariatric surgery as a treatment option. However, over the past decade, we have noticed that the number of bariatric procedure essentially has plateaued. I want to thank Dr. Jaime Ponce and Anita Corkelis for heading up the bariatric number task force. As you can see here, between 2001 and 2013, the number of bariatric operations being done in the US ranged somewhere between 160 to 180,000. According to the US Census data, it estimates that 319 million people lives in the US with 242 million adults. 36 million of these individuals are considered severely obese, and 26 million are eligible for bariatric surgery. So if that's the case, we are providing optimal care in less than 1% of the eligible patient. If you look at our vision, the ASMBS Vision statement states this: to improve the public health and well-being by lessening the burden of the disease of obesity and related disease throughout the world. Therefore, my talk today is really on ways we can work as a group to achieve our vision. To achieve this vision, we need to move what I call the therapeutic needle. We have to improve and optimize the number of patients that can get this procedure. So my focus for this past year is really establish building blocks that we can build upon to achieve our organizational vision. First and foremost, to move this needle, access has to be at the forefront. Our patient must have the ability to access the entire continuum of obesity treatment. I want to thank Dr. Wayne English and Dr. Matt Bregman, who chair the Access to Care Committee and also the Insurance Committee, respectively, to continue to push our effort at coverage and access to bariatric surgery. Our patient needs to have access to the entire spectrum of treatment, similar to the treatment of any other chronic disease. And here's just a list of the spectrum of treatment for most chronic disease. You start out with lifestyle modification, dietary modification, medication, and then invasive therapy/surgery. For example, treatment of mild to moderate renal disease include dietary modification and medication. For severe renal disease, you have invasive therapy such as dialysis and even transplantation. What if a patient with renal failure do not have coverage for renal dialysis or transplantation? I don't think any of us will tolerate that. I think Dr. Sharma said it best in his editorial for Journal of Obesity, that bariatric medicine without bariatric surgery is like management of nephrology patient without dialysis. This is an article published by the Associated Press that came out earlier this year, and the writer echoed what we know already. The number of obese Americans has not changed over the past decade. The number of bariatric surgery have not budged, and less than 1% of eligible patients are getting what we call optimal therapy. Under the Affordable Care Act, only 22 states have bariatric surgery coverage. And even worse, only 5 states have coverage for weight loss program. That's why this past September, we worked with the Obesity Care Continuum and published this ad in the Capitol Hill newspaper. And really, it's called the attention to how state exchange are discriminating against those with obesity. And it's just not us. Many of these organizations here sign on to the ad and supporting our effort. Pushing for coverage is not new to our organization. This is the coverage map for sleeve gastrectomy in June of 2002. And this is the coverage map for sleeve gastrectomy as of February of this year. We can thank our President-elect, Dr. John Morton, who really championed this effort when he was chairing the Access to Care Committee. We also making headway with coverage by public employer. There are a few states left that need support, and we're fighting state by state, and we need to convert all these states to the color blue. And that's exactly why we established the state chapter of the ASMBS, whereby the local leaders in these individual states can work to respond to local access issue. I want to thank Chris Joyce, who's currently the state chapter president chair, and he has planned to change all the black state, which does not have a state chapter, to green state. This is just an example of how a state chapter championing the coverage issue can really win for our patient. So Dr. Ranjan Sudan, state chapter president of North Carolina, worked with Blue Cross Blue Shield to essentially remove the 6-month medical weight loss requirement. And certainly, with coverage alone does not equate to access. Similarly, Dr. Titus Duncan, who is the president of the state chapter of Georgia, working with Dr. Jaime Ponce, were able to work with the Georgia Governor Nathan Deal to sign and approve a pilot program in bariatric surgery for the state public employer in Georgia. You already know that in 2013, we won big with the American Medical Association when they came out with a resolution that obesity is considered a disease. But in 2014, we had another win with the Resolution 111. In that resolution, it states that patient access to evidence-based obesity service should be covered, including behavioral counseling, FDA-approved drugs, nutritional, and also metabolic and bariatric surgery. At the same time, the ASMBS was also given a seat within the House of Delegates of the AMA. Certainly, this is a big win for us and for our patient. I want to thank Jaime, John, and Georgianne really for their effort in getting us a seat within the AMA House of Delegates. However, to move this needle, improving access alone is just not enough. These are the three-pronged approach that I think we need to move the needle. First, we need to look upon our organization to see what we can do to improve the care of our patient, certainly through innovation and research. Second, we need to engage our medical colleague, first to understand why they are not referring their patient to see us for discussion about bariatric surgery. And third, we also need to engage our patient to seek out the treatment for the disease of obesity. This year, I initiated a development group. It's called the Development Liaison Group, headed by Dr. Mitch Roslin, essentially to help me with these three initiatives. So the question is that what can we do as a group to improve the care of our patient? Well, we are surgeons. Certainly, the first thing and foremost is we have to make our surgery safer. And we started that with laparoscopy. That was a huge revolution. And you can see that as a group, we evolved. Laparoscopy probably started around 1998 when there's several implementation centered around the nation. And then as you can see here, by 2005, there were more laparoscopic bariatric operations being performed than open bariatric surgery. But with the recent article here published in New England Journal of Medicine here, what they found is that there's correlation between improved technical skill and reduction in postoperative morbidity. So this tells us that there's an opportunity for improvement to make our field even safer. There are a variety of ways to learn surgical techniques. First is really our annual meeting here. But another way is really for the trainee to go see one of the expert surgeons and learn some of the tips. We are collaborating with SAGES on what we call the SAGES ASMBS Sleeve Telementoring Project. So the issue of traveling to observe a case is that it is time-consuming and it's very costly. With telementoring, essentially, you just eliminate the entire travel process. For example, in this picture here, the surgeon is in Guatemala, and he's watching me performing a sleeve gastrectomy in California. And vice versa. I'm sitting in my office and proctoring Dr. Keith Sharp at Loma Linda University. It's not that Dr. Keith Sharp doesn't know how to do a laparoscopic sleeve gastrectomy, but it's always good to get pointers to improve your technical skill, reduce operative time. I think soon this model can be expanded to train surgeons in other complex operation or innovative procedure. Next, we need to continue just reevaluate how we can enhance the educational experience for our members. The Executive Council a couple years ago noted that we do not have a concise resource of information. So 2 years ago, we embarked on developing what we call the ASMBS Textbook of Bariatric Surgery. And I am extremely happy to tell you that this work has been paid off. The book is available here at our booth. This book is 2-volume textbook. The first volume is devoted to bariatric surgery, and the second volume is devoted to bariatric medicine, psychosocial, and nutritional aspect of bariatric surgery. I am grateful to all the editors who contribute to this book, and also all the authors who worked so hard to make this book a reality. Volume 1 has 43 chapters with contribution more than 70 authors, and Volume 2 has 22 chapters with more than 40 contributors. This textbook has ample, easy to understand graphics, photograph, drawings. Here's an example of drawings of investigational bariatric procedure. The duodenojejunal bypass, as you can see there on A, and then B, which is the ilio interposition. Later this month, I'm going to be giving a talk on the outcomes of conversion from gastric banding to sleeve gastrectomy. So I decided to look up this chapter on reoperative option after gastric banding and found this table really summarized everything, all the clinical series reporting the perioperative morbidity, weight loss outcome, and I use this in my presentation. At the end of each chapter, there is a question and answer section to test the knowledge of the reader. For example, this is a chapter by Dr. Kothari here on the impact of bariatric surgery on fertility. And as you can see here, these are the questions. Question number 1, increase of all the following are contributing factor to the development of polycystic ovarian syndrome. A, and you can read down the line. Certainly, I'm not going to tell you the answer, but certainly I think you should buy the book because the answer is provided in the back of the book. So to your right there, that's the first time I actually saw the book, which is at the American College of Surgeons. And to your left there is I give as a present to our president of IFSO a signed book. So tomorrow we actually have a book signing event. So certainly if you bought a book here, please bring it by tomorrow at noontime in the exhibit hall and come say hello to all of our editors. Besides education, we need to continue to deliver high-quality research. And research is why we are here today. Between 2007 and 2012, all of us who participated in the ASMBS accreditation program has entered data into what we call the BOLD database. I'm happy to announce now that soon the ASMBS COE database will be available to you. This database has more than 420,000 patients accrued with 30-day perioperative outcome. I want to thank Dr. Ranjan Sudan and the entire research committee who championed this project and able to convert millions of data points into easy-to-use file. This should be up on the website soon, so look for it. Along the line of research, I'm happy to report that our surgical journal, SWORD, is now ranked in the top 10. It's actually 7 out of 200 surgical journals, and we achieved this in a remarkable short time period. This is unprecedented, and certainly is because of this man on this slide. This is Harvey Sugarman, who is our editor-in-chief. His leadership has helped us achieve this status and recognition that bariatric surgery is a legitimate subspecialty within our surgical community. I also want to acknowledge that this is actually our 10th anniversary for SWORD. So if you see Harvey, please congratulate him. Next, as a group, we just need to continue our quality improvement effort. And that is the MBS AQUIP, which is stronger than ever. Our collaboration with the American College of Surgeons is now considered a success. We are more than 700 centers strong. And now, with plans for development of a pathway for participation of international program. So let me show you how we have transformed as a group. Previously, we worked by ourselves. We are autonomous. Now, we get together, we're collaborative. Previously, we don't measure anything. Now, we have a mechanism to capture 100% of our data. Back then, we want to keep everything to ourselves. Now, we're transparent. For what is state, previously, I think we have a lot of self-interest. Now, we looked out for the public. The public interest is first. And certainly, we need to capture the public trust. This is the bariatric surgery training committee curriculum for our young. So for fellows in fellowship in bariatric surgery, there is curriculum that include cognitive and clinical requirements. And once you achieve that, you can get an ASMBS certificate of recognition for graduating fellows. This is how we train the next generation of bariatric surgeon. Now, there's an opportunity working with the American Board of Surgery to get what we call Certificate of Added Qualification in Bariatric Surgery, meaning that our trainee who complete an ASMBS fellowship training curriculum may qualify to take this validated examination administered by the American Board of Surgery. What's the advantage? This certificate will ensure the public trust, improve our knowledge of the trainee, and enhance the legitimacy of our field. Certainly, we're not alone. Other societies with non-ACGME fellowship are evaluating this type of certificate also. These include transplant, hepatobiliary surgery, acute care surgery, transition to practice, burns, breast and foregut surgery. Recently, we sent out a request for comment from our membership on this issue, and many of the members stated that they would like also to have a pathway for practicing surgeon to obtain such a certificate. So we're working with the American Board of Surgery to look at this proposal, and we will keep you updated. Next, we have to engage our medical colleague to routinely evaluate their patient for obesity, initiate therapy, discuss the treatment option, and certainly refer appropriate patient for bariatric surgery. As you can remember, the 2013 American College of Cardiology, the American Heart Association, and TOS guideline on management of adult obesity, it states that physicians should, 1, measure the weight of their patient, 2, initiate obesity treatment, and then 3, refer patient with BMI greater than 40 or BMI greater than 35 with obesity-related comorbidity for consultation. The question is, how can we engage the primary physician to start implementing this guideline? So one of the initiatives we done this past year was really an outreach to our medical and surgical colleagues, and the focus is really on the topic of obesity treatment. In Chicago in September, we had this summit. It's called the Summit of Provision and Coordination of Care for the Obese, and we were able to get together more than 20 medical and surgical national organizations. And our focus of discussion was on the topic of obesity treatment. This is unprecedented to get all these organizations to sit in the same room. I really want to thank our president-elect, Dr. Morton, who did an exceptional job in coordinating the entire event. The whole concept of this idea started in January. We did the invitation in June, and we implemented in September. There are so many discussions. These are just some of the examples of discussion by representatives from organizations such as ASBP, TAS, the American College of Orthopedic Surgeons, the American College of Sports Medicine, the American Diabetes Association, the American Association of Clinical Endocrinologists, the American Academy of Nurse Practitioners, the American of Heart Association, and these are just to name a few. These are the entire list of all the organizations that participate and join in our discussion. We use interactive polling system and were able to get some understanding from the group, the current state of obesity treatment among our medical and surgical colleagues. This was one of the questions. It says, have you recommended obese patient to obese medication? 78% responded yes. Have you recommended obese patient to bariatric surgery? I was a little surprised, but 92% responded yes. But remember, these are the leaders of their organization. This might not be the same answer if we have the same poll of their membership. This is the entire group. And you can see here, a lot of work went into putting this meeting together, and this is only the first step. John has planned to follow up with each and every one of these organizations. We need to administer a survey within their membership on the understanding of obesity treatment and possibly bring together a white paper on the principle of obesity treatment that we can all agree upon. Thanks, John, again, for the great first meeting. And we plan to have this an enduring meeting and work with these medical and surgical organizations yearly. So if you ask your medical colleague on the reason why they do not refer a patient for us for bariatric surgery, one of the reasons on top of the list is that they worry about complications associated with bariatric surgery. They recognize now that the mortality associated with bariatric surgery is really low. But what about the complication, particularly long-term complication? So what is really the research evidence gap that we need to answer? This is actually a recent publication from the NIH Symposium on the topic of long-term outcome in bariatric surgery. The authors here conclude that more information is needed about long-term durability and comorbidity control and complication after bariatric procedure, and that this evidence will most likely come from a carefully designed observational study. They state that there is a lot of challenges in conducting a large long-term randomized trial in bariatric surgery, and continued investment should be on high-quality, carefully designed observational study. So this is another one of our initiatives here. We call it the MET-MET trial, prospective observational cohort study of metabolic surgery versus optimal medical therapy. I think the word here is optimal medical therapy to include pharmacotherapy. The inclusion and exclusion criteria is listed here. 35 to 60 with at least one comorbidity, no previous foregut surgery. This is a large study involving 750 to 800 study at 6 institutions. I'm happy to announce that the funding of this trial is very positive at the current time. And I want to thank some of the industry partners who are committed to support this effort, and certainly also the ASMBS Foundation. This is a comparative effectiveness trial. We're going to have an algorithm to try to understand if a patient with a BMI 40, where should they go? Dietary management, bariatric surgery. If it's dietary management, what is it? Dietary in combination with pharmacotherapy or just dietary management? Eventually, we will construct what we call obesity management algorithm to help patients and their primary care navigate what is the best treatment option for their patient. Lastly, I want to touch on this topic of patient engagement. This is a very important area for us to address to move the treatment needle. For every one patient who is unable to get access to bariatric surgery, there are likely more than 10 patients with access to bariatric surgery but are not taking initiative in getting obesity treatment. We asked this question at the Obesity Treatment Summit. How confident are you that the general population understand the implication of obesity disease? And as you can see here, 80% of the respondents state that they are not confident at all that our patient really understand the implication of obesity. So certainly we have an educational hurdle to effectively treat obesity for our patient. We have to educate our patient. So we ask again, what do you perceive as a barrier to obesity treatment? And again, as expected, access to care is at the forefront. But number two is patient engagement. They need to engage to care. Some of the patient feels that surgery is too drastic. They are afraid of not getting the desirable outcome, and some are just not ready for that big step. So we also ask another question. What do you recommend to increase patient engagement? And as you can see here, the highest support was some type of public awareness campaign. So last year at this time, we embarked on creating a public campaign in the form of what I call it, a patient educational, motivational, and most of all, inspiring video. I would like now to share with you the lives and struggle of 3 individuals who struggle with obesity and their journey to a healthier life with bariatric surgery. Let's all watch this video.
Every day, people throughout America are discovering a tool that enables them to take back their lives.
What do they want out of life? Do they want to live the way they're living, or do they want to make some changes?
Discover how a Navy veteran, a Stanford nurse, and a former NFL player used weight loss surgery to overcome their struggle with obesity. These are their stories.
This is only beginning now, the start of the journey.
You gotta start doing something.
I'm a nurse at Stanford Hospital. I just had a desire to be around sick people. I just felt like I could make a difference with them. When I hit 40 and tried to have a child late in life, I started taking infertility drugs, and I was successful in having a child. But at the same time, I had gotten my weight out of control, and I just didn't know how to get it back down to where it was. I didn't want to admit that I was that heavy and that out of control and not going to be able to get through it on my own. I was on the path to getting diabetes, getting high blood pressure. As part of my workup, I had an echocardiogram that showed I had left ventricular hypertrophy. I knew that was a setup for getting congestive heart failure.
I was a surface warfare officer. I served 5 years in the fleet on 3 different ships. When I left the Navy, I became what we refer to as fat, dumb, and happy. And I allowed myself to let go. I sank into depression, stopped working out, stopped taking care of myself. At 300 pounds, I was literally twice the man I should have been. I suffer from sleep apnea. When I left the Navy, I was 180 pounds, and within 5 years, I was 300. I looked at the picture and I didn't recognize myself. And
I knew I needed something, some tool, some mechanism to help me manage it.
I worked with my primary care physician. She just very gently said to me, have you ever considered bariatric surgery?
it came down to what are the risks of doing nothing versus the potential gain.
You get a headache, what do? You take an aspirin. Having weight loss surgery is just a procedure to get you where you need to be.
I just decided I was going to do it.
It is a pause button that allows you to reset. It was a good week. I lost 5.6 pounds.
The reason that I decided to go towards the surgery is that I want to be a parent.
The weight loss surgery has positive impact within a matter of weeks. As soon as the discomfort starts to fade, you begin to notice that you are dropping weight 4 to 5 pounds a week.
When I think about the fear that I had facing surgery and knowing now what I went through with the surgery, I don't want to trivialize it, but it was really not that bad.
There are several days in my life that I remember vividly, and the day of the surgery is the top of the list. This was the beginning of a new period for me.
I look at the world differently now because I feel like I can engage in everything. And I felt like before I had to sit out on some things, and now I don't have to sit out anymore.
I played 10 years in the National Football League. I never won a championship. This is the first thing that I can honestly say that I felt that I won. It's the best thing I ever did.
Thank you. I want to thank the following members for their ideas and contribution in construction of this video, particularly Dr. Raul Rosenthal, Dr. Roger Kissin, Dr. Joni, and everyone listed there. And certainly I also want to thank the Corporate Counsel for their support of this video. This video will be available to all of our members to be placed on your website. And certainly, I think all of our patients who looks for information regarding bariatric surgery will likely see this video and hopefully inspire them to get treatment and more information at asmbs.org. So now, that kind of complete my talk to you. I just want to take a little time to thank and acknowledge some of the people who kind of shaped my career and helped me, this past year to advance the vision of our organization. I said this at the initial opening session. I recognize the past president, and I think that's very important because these are the people that paved the way for our organization to be here. Everyone that's standing up there right here. We would certainly not be here without you, so I thank you. I want to recognize my mentor, colleague, and a friend, Dr. Phil Schauer. He's one of our past presidents. I met him in 1995 when I went to University of Pittsburgh as a fellow. And at that time, I was a fellow in surgical oncology. And I rotated with him, and we did a lot of laparoscopic procedure, particularly laparoscopic hiatal hernia, anti-reflux surgery. But there was one operation that stood out. He started performing this first operation, and it's called the laparoscopic gastric bypass. And when I saw that, I just knew I was witnessing history in the making. After fellowship, my first position at the University of California, Davis, is really with Bruce. I show this picture because Bruce is the healthiest guy I know, unlike that of Dr. Schauer. He biked, he's an avid skier, and really he was the one that supported my endeavor to initiate the randomized trial between laparoscopic versus open gastric bypass. Thank you, Bruce, for all your support over the years. I have to recognize my UCI team. To the left picture is really the entire resident and fellow. And then to my right are my clinical staff and also my friend and colleague, Dr. Brian Smith. In there, my bariatric coordinator, Sharon So, our dietitian, Amber, and Janet, our social worker. Thank you. And what can I say to this group? This is the executive council. This is the group of people who have devoted so much of their time to grow our organization. I want to thank you, each and every one of you, for this past year. Your contribution to society is greatly appreciated. I want to thank the executive committee, Dr. Raul Rosenthal, John Morton, Jaime Ponce. Here we are visiting Dr. Ed Mason home. Special thanks to the 3 Amigos, and it's official now. This is actually a picture from yesterday, presidential dinner. Dr. Morton bought us the Amigos hat, as I call it. So I guess this is official. I want to recognize G and Jen. Anybody know who G is? G, can you just stand up? G stands for Georgianne. Georgianne is our executive director. And really, she's the spine of this entire organization, and she makes everything happen. And following that is really Jen. Jen, if you need anything, Jen can make it happen. So thank you, Georgianne. Thank you, Jen. Appreciate everything you have done for us. I certainly want to recognize our international colleague. I stated at the international reception last night, the future of this organization is international collaboration. We have to collaborate. The ASMBS and IFSO leadership are working closer than ever to advance the science of obesity and bariatric surgery. So I still have a couple more people I need to thank. And I'm going to tell you a little bit about how I got here. And not how I got here as the president of the ASMBS, just the road of life of how I get to where I am right now. Certainly, it was a rough road, a road with adversity. This is where I was born, Saigon, Vietnam, as alluded to by Jaime Ponce, now known as the Ho Chi Minh City. But my childhood was a happy childhood just like all of you. Here it is, I'm driving my brand new car, but directly imported from America. I have no idea where America is, but I just know that all these toys were coming in from America. So every holiday, my dad would give me a catalog. It's called the Sears catalog. And you just order whatever you want. We're relatively wealthy over there. So me and my brother here are the talk of the town because we have the latest and greatest toys. But it wasn't that pretty. These are the magazine cover in the late 60s and early 70s about a war. It's called the Vietnam War or conflict. And at that time, the war was in full force. By 1973, the war was beginning to wane. And then certainly by 1975, this cover of Time magazine stated all. The US troops are retreating, and the South Vietnamese are in position to acknowledge defeat. This is the timeline of how I arrived to America. On April the 24th, as a family, we all went to the airport, and I said, why are we going? We are going on vacation. Where are we going? To America. I said, this is great. My final chance at going to see all the toys. I said, can we bring the dog? My mom says, no, leave the dog. Certainly, I never saw the dog again. So we went to Guam. 3 days later, April 27th, 100,000 North Vietnamese troops encircled Saigon. So this is our civil war, the South versus the North. And they attacked the airport. There is no more leaving Vietnam. I don't know what would happen if we stayed. My dad worked for the American embassy in Saigon. And as you can see here, communists are taking over. By April 30th, the last US Marine evacuated the embassy by helicopter now because there is just no way to leave Vietnam through the airport because it's been attacked. And we call that the fall of Saigon. This is the actual picture of that last day. On April 30th, 1975, the helicopter landed on the US Embassy in Saigon. And essentially, there's a whole line of people trying to get on that helicopter, but only Americans were able to get on. We were just lucky that we got on that flight only 4 days previously. So by July of 1975, our family arrived to America. And as you can see, the entire family, the 4 siblings, my parents, aunt, uncle, and grandmother, and behind there are what we call our sponsors. So certainly, we really don't have any money. We just came to a new country. So our sponsor, who are 2 individuals that worked with my dad at the U.S. Embassy in Saigon, they knew us and able to bring us into their home and open their doors. This is an article that says, sponsors refugee family faces hardship and has hope. And certainly, we have to start rebuilding, essentially starting from scratch. And for the kids, it's easy. As you can see right there, we're learning English, and I think the teacher's asking us what is 11:15, and me and my sister got it right, but look at my brother. And guess what? He's a dentist now. So my parents now have to start from scratch. So what they did is an entrepreneur spirit takes on. And with adversity, that's what you need to do. And they started a clothing factory in our garage. So unlike most of you, when you go home from school, you get to go out, play with your friends and everything. I go to work. So we sew. We all learn how to sew, every single one of us. back then, I don't think there's child labor law. I was only like 10 or 13. My mom is sitting here, so she knows. But it really doesn't matter. It doesn't matter about the work. We all contributed through adversity. So when I get to junior high school, I would go out with a lot of my friends, and they were wearing, a lot of nice clothes. And, as children, you want to be part of the crowd and everything else. Obviously, we don't have that kind of money. So we normally shop at thrift store. So at that time, the in thing is really to wear Guess. Older surgeon like Dr. Phil Shao kind of understand that. Back then, Guess was really in. So you know what we would do? I would go to the thrift shop. I'd buy this Guess shirt. It's really raggedy because it's probably have a rip in it. That's why it was at the thrift shop. But what I would do is that I just take the tag off the shirt, and I go buy the fabric and actually make a shirt. I put the tag on. I just got my brand new Guess shirt. And actually looks even better than the regular Guess shirt. So the people I want to thank the most is really my parents. And my dad cannot travel that far, but certainly I know he's thinking of me. My mom is here, and I think she would be very proud of where we came from. What I can tell you now, we don't have to shop at thrift store anymore. Cảm ơn mẹ. That means thank you, Mom. And really, this is what I have to thank for. Where else in the world can you come and start from nowhere and nothing? This is the greatest country in the world. Sometimes we take it for granted. When they say America is the land of opportunity, I can tell you, take it from someone like me, this is the land of opportunity. It's truly been a privilege and an honor to be your 28th president of the ASMBS. Thank you.